again. So this is a new module, systemic pathology after general pathology. So as I said, in general pathology, so in systemic pathology, we'll be applying the principles we learn in the general pathology. We apply them to different organs. So basically, for each organ, we should discuss all the diseases, but that is not possible because the diseases are so many and nobody knows the number of disease entities that exist. There are very many. So we will choose a few, but you should keep in mind that for every organ, so we have a developmental or malformation diseases. Then we have infections or inflammatory diseases. And remember what we saw in inflammation. They can be acute or chronic. Then, and healing dependence, so on. We have hemodynamic changes or abnormalities in any disease they can exist. We have benign tumors and we have malignant tumors or cancers. So that is in general what we should cover for each of the organ. But because there are many, we cannot do that. That's why we will just choose a few diseases. Most of the time we choose the most common diseases to discuss. Otherwise, as you go on, you should also take time to read more about these diseases. So with the short time we have for the lectures, we cannot cover everything, but in your free time, you have to read, and that's how people, some they become good doctors, others not. It depends on many things, including interest you have in learning more than what the lecturers have presented. So in a sequence of teaching the systems, usually we start with cardiovascular system, but it depends, but usually we start with it. So this presentation is the same as the one we used last year for last year lectures, but for the other systems, like from digestive system, so I have already prepared the new presentations. So I was done yesterday preparing the digestive system, so I will go on also preparing new presentation for most of the chapters, because there are some few changes which have happened in pathology, especially in tumors. So that's why we have to change. So this is these are the references. So Robin's basic pathology. We have also these other two books, but Robin's is the basic one, and I hope you can have it. So whenever you have a question, you will just open your microphone and speak. Yes? You have a question? Okay, maybe no question. So you heard these presentations on Monday, so I hope you have gone through. So I will be quick because I hope you had time to go through them, to go through the macroscopic or gross images, and through the links I sent, and also there are the quizzes you should have gone through, because most of the time we chose some questions from the link we shared with you. So otherwise, if you can have what we call a basic pathology review, it is a book just for exam questions. So it is based on Robbins, and so that book is like an appendix to the Robbins book, to this first one. So if you can go through that also you will. When you read the questions and the answers, usually also you get more insights, not only to know the answers, but also you understand more about the lectures and diseases and so on. So
lecture question.
yes, you can ask question.
We didn't get the books that you have mentioned.
The first one.
This Lobin basic pathology is the one which the Lisa questions.
I don't get your question.
Lecture, you have recommended us to read some questions in which book?
First of all, I sent links. One link was for quizzes. Have you seen that?
Yeah, we have seen it.
Okay, so another one, this book, it has it's appendix book. It is called like Basic Pathology Review Board, things like that. So it has only questions and answers. But the questions were taken from they referred to this book itself. So usually when you go to the United States or other Anglophone countries, most of the questions they ask you in pathology, they are taken from that book.
Oh, yeah. It's fine.
Okay, so for other chapters, there is a book I am using to prepare the new presentations. So it is not large. That one I can share it, but it is it doesn't have any questions or answers. So it is just for reading, but it is a good book for reading. I will send it, but Robin is I cannot send it. It is too heavy.
Yes.
So we start with the heart. As you know, the heart has chambers, 4 chambers basically. So we have a left ventricle, right ventricle, and then we have atrium, the right one, and the left atrium. And this, the left and the left atrium and the left ventricle, they are separated by a bicuspid valve or mitral valve here, and we have a valve also separating the right atrium from the right ventricle. This is the tricuspid because it has 3 cusps, while this one has 2 cusps. And also have a valves in the aorta and in the pulmonary artery. So all these valves, you know, their functions, when the heart is pumping blood, it is to avoid the regurgitation of the blood. So that's their main functions. And in cardiology, you will have learned that this is important. Because when these are not working properly, there are problems. So hari abo usanga zino zidafata ahubwo tukabyita mitral valve insufficiency, for example. Icyo gihe bituma iyo left ventricle yohereje amaraso muri azamutse muri aorta azakomeza, bituma amaraso asubira muri left atrium. Iyo asubiyemo rero, icyo gihe bijena amaraso yandi yavaga mu bihaha avuye gusukurwa aje muri left atrium. Icyo gihe bikagera consequence yenda bizamuka ku bihaha. So ni kimwe nuko habayeho ikibazo hano kuri right ventricle. Iyi valve itandukana right ventricle na right atrium ikaba insufficient igihe hariho umutima uri gupompa amaraso hano ahita asubira hejuru ahanga yahita asubira muri vena kava ziba zayazanye ahangaha, bityo bikagira ikibazo muri periferi. So ibyo nyirawo muzabyiga muri cardiology, ntabwo tubitindaho. So the same for the aortic valve, niba iyo ishinzwe kugira ngo amaraso igihe umutima amaze kohereza amaraso agahita muri iyi valve akajya muri aorte, atagaruka inyuma. Agarutse inyuma yahita agaruka muri left ventricle. So ugasanga umutima wenda wabyimbye n'ibindi. So icyo ni kimwe. Hari ukuba izi valve zishobora kuba insufficient, ni ukuvuga ntizihagarika amaraso ngo ziyabuze gusubira inyuma. Indi indi scenario ibaho nuko ahubwo izi valve zifunga cyane ziba stenotic ku buryo amaraso n'igihe umutima n'igihe zigomba gufungurwa mu zemera amaraso atambuke adashobora kunyuramo neza, anyuramo abyigana and so on. So ibi byose iyo mukora auscultation hope you have run that, urabyumva icyo kibazo gihari. So ku buryo yo ukora auscultation ku muntu ushobora kumva ko afite insufficiency of the valve cyangwa se ko afite stenosis, kandi ukamenya ngo iyi valve ni iyihe ku mubiri w'umuntu ku gituza, ukamenya ahari. Ibyo muba mwarabyize muri semiology, aho signs and symptoms, aho ibyo bimenyetso byose ubona, ku buryo as you are working in this little hospital it will be very easy at least to identify, to say in this patient I heard there is probably insufficient mitral valve, or there is a stenosis of the mitral valve or the aortic valve and so on. Then you refer to the cardiologist with a good note and so on. And also, if you have to save that patient before sending, referring him or her to higher level hospital, you have also to know what is the problem there so that you can intervene before sending that patient. So, but here in the pathology, we will focus more on diseases affecting, for example, these muscles, the muscles in the ventricles, and we will look also at the issue of ischemia, meaning usually these vessels we are noticing the coronary arteries. As you know, when the aorta gets blood, there is a small amount of that blood which comes back to nourish the heart itself through aortic, through the coronary arteries, and so on. So sometimes these coronary arteries, they get thrombosis or embolism. I hope you remember what we have seen last time. So when there are these the such coronary arteries, it can cause heart attack or myocardial infarction. So other diseases we see, there are those affecting the endocardium, because in this layer, as you know, you remember in histology, we have the muscle, but the innermost layer is endocardium and the outer layer is pericardium. So we have diseases for pericardium, diseases for endocardium. Mostly they are infectious diseases, and these are severe. Ni indwara ziganje cyane. So muri ibitaro bya Sashka, muri office nkorerana n'umu cardiac pediatrician. So pediatrician ufite subspecialty muri cardiology. So nizo ndwara ahura nazo cyane, ni infectious disease affecting these valves and the endocardium itself. So usanga abenshi bari abana bakabohereza mu kubagwa, cyane cyane mu bihugu bya Israel, muri Egypt, mu Burayi, rimwe na rimwe bakabagirwa hano iyo haje team zibabaga. So ni indwara ziganje, ntabwo ibyo tuvuga ari ibintu byo mu bitabo. These are real things even here. So, and as you know, this is the, okay, let's start with B. Here you see that the ventricle, they are contracted. So ventricles, they are pumping blood, and the blood will enter through the mitral valve, not mitral valve. So they enter through the aortic valve, which is open here, and continue in the aorta. And for this to happen effectively, the mitral valve has to be closed. So now you umutima upompa amaraso yohereza muri systemic circulation. Okay, uyo upompera rimwe, ariko iyo ventricles zipompya amaraso, valve zifa kuri atria zombi zihita zifunga, kandi amaraso adasubira inyuma. Ahubwo valve zo muri aortic, muri aorta nizo muri pulmonary artery akaba arizo zifunguka kandi amaraso agenda. Mu gihe iyo ni systole. Muri diastole, ahangaha ventricles ziba ziri relax, ahubwo ziri kwakira andi maraso nawe ziri bupompe nyuma. Icyo gihe rero izi valve zo muri atrium nizo ziba zifunguye, ahubwo valve zijya muri aorta na pulmonary artery akaba arizo zifungwa. So this is how our hearts are created. So coronary arteries navugaga murazibona ahangaha, so they are important and it is important to know them. They are branches, amazina yazo, posterior interventricular branch, anterior interventricular branch, and so on. So you have to know it in anatomy. Kugira ngo igihe uzabona umuntu wenda agizemo embolism bakavuga ngo ayifite muri anterior interventricular branch, uzamenye ni hehe nubwo utamubaga, ariko when you do cardiac surgery, because I think in the near future we'll have a cardiac surgery specialty here or subspecialty here, kugira ngo uzamenye ni hehe. So nutabimenyera muri undergraduate hano uzabimenyera ahandi. They are supposed kubizi. If you go abroad for studies, ntabwo ari ibintu bazagusubiramo, bo bazavuga bati ikibazo cyabonetse kuri angiogram, babonye ko ari anterior interventricular branch. So they will suppose you know where it is, so that if they open, they will not tell you this is what. No, they will not. They suppose you know there's a things. So the blood supply to the heart is composed by coronary arteries in the vein. So we don't have to take time on this. And the valves, I have talked about them. They prevent the backflow of the blood. So the coronary artery diseases, they result from coronary arteries which cannot deliver blood adequately. So murumva ko dutangire ku bibazo birajya kuri ischemia, we start with the coronary arteries, meaning we are going to see the problems to the heart itself. Ntabwo ari ibibazo tugiye gutangira byo igihe umutima wenda udakoze ibikwiriye, consequences ziba ku zindi organs. So here we start with the problems of the heart itself. So it ensures angina pectoris. If you remember well what you learn with the Tamiri in cell injury. So when our myocardium doesn't get enough blood for a few seconds or a few minutes, they say below, I think below 20 minutes, igira icyo bita ischemia. So ischemia, it is a condition preceding infarction. So ischemia, umubiri ukirwana ariko selile ziba ziri injured but irreversibly. So meaning that if you supply blood, there's a cells, they will not die. So ku mutima rero iyo ischemia ijambo rikoreshwa ni angina pectoris, niyo ikunda gukoreshwa. Angina pectoris ntabwo ari angina mu gifaransa ntabwo ari kimwe. So angina pectoris, it is that condition in which there is a pain in the chest. You see pectoris here in the chest because of insufficiency in blood supply to the heart itself. So myocardial infarction is when the angina pectoris has been there for a long time. For more than 20 minutes, the heart muscle cells will no longer be able to get life, to come back to life. So they will die. So this is myocardial infarction or necrosis. So ariyo bita heart attack muri terime zo hanze. So the most common reason of this is the atheroma. So I think we have seen thrombosis, atheroma, and so you remember atheroma means there is a atherosclerosis. In atherosclerosis, there is first a fat which accumulates. So when the fat accumulates and in the tunica intima, between the intima and the media, usually there are macrophages which will come to fight. They will engulf there's a macrophage, there's a fat. So unfortunately, usually there is additional fat which comes in, so that the macrophages will not be able to engulf all the fat. So therefore, there will be fat in the interstitial area, and this fat will cause the recruitment of more inflammatory cells, lymphocytes, and the others. So because these are they fight, there are some tissue cells which die. And in repairing, there will be fibrosis and so on. Uko bikura nibwo rero hagenda habyimba, mu kubyimba icyo bikora ni atheroma. So this atheroma will be composed of macrophages, fat, fibrosis, inflammatory cells, so many things there. So the consequences is that the lumen will be occluded. So, and you see on this upper side here, the wall of the vessel is small, or is not thick. On the contrary, here you see that there is a thickness has too much increased. The thickness has too much increased, and the lumen is very small. So the lumen being small, this will have consequences on the quantity of the blood which should pass through here. So niba hanyuraga amaraso mililitiro zingahe zikagabanuka, birumvikana umutima wari ukeneye amaraso yanga ukore uzagira ikibazo. Mu kugira ikibazo serere zimwe na zimwe ntizizashobora kubona amaraso, oxygen and nutrients, then you will undergo ischemia. And here, when there is atheroma, as the atheroma grows, there will be additional calcification. These blue things, these are the calcium deposits. So that is the lumen, and this is the calcification in the atheroma. So here it is almost completely occluded by the thrombosis. For me, as I'm experienced in pathology, so I can see even cholesterol cleft. Needles. Actually, we call them cholesterol clefts or cholesterol needles. So is it ni cholesterol iba yahuye na calcium, then bigakora salts, twari utuntu tujombana, they are needles. Already are microscopic, turanajombana, tukajomba amaserire, akarushaho gupfa ari menshi. So, and this thrombosis is just inside the lumen of the coronary artery, and understand the consequences. So usually this is a true section. It means it was taken from someone who had a thrombosis in the coronary artery. Usually these people, they die. So thrombosis and so on. So the complications for this atheroma, as I was explaining, in the coronary artery, it will be myocardial infarction if we are dealing with the heart. If the atheroma or thrombosis happens in the cerebral arteries, it will cause a stroke. If it is in the peripheral tissues, for example, the limbs, the lower limb, upper limbs, in the let's say the intestines, it will cause a gangrene. So gangrene, it is also a necrosis, but ahangaho ubusanga hano habaye necrotized, habaye umukara cyane. So ikunda kuba ku bantu bafite diabetes and so on, bikagara ukuguru, it becomes necrotic and black. So if it happens to the kidney, it will cause, of course, kidney failure, because the kidney will no longer be able to do glomerular filtration. Other consequences are aneurysms. It means there is a subrupture of the wall of a vessel somewhere, and it can be a complete rupture and a thromboembolism. So I think this is what we were explaining. So here we have, this is the picture, I think you remember it in atherosclerosis. So here we have a fatty streaks. So ni fat gusa yaba deposited. Here you cannot see it grossly. Ariko iyo urebe muri lumen washute nka vessel uri kubaga umuntu cyangwa se kuri autopsy, ubu uzibona ko harimo ibintu by'umuhondo muri munsi ya endothelium. So here it is a fibrous plaque katangiye kugaragara gatoya. It grows, and here now it has complications. I think you remember this we discussed in hemodynamic disorders. So there was an atheroma, it becomes ulcerated and or ruptured and causing an additional thrombus here. There is a blood clot here. So the atheroma can be complicated in many ways. Thrombosis, as you see it here, rupture. So here they are combined with hemorrhage. So I think in this, three are combined. There is thrombosis, there is a plaque rupture, and there is hemorrhage. Hemorrhage, of course, is the one causing the thrombosis. And then there can be weakening, which may lead to aneurysm, so which is not presented here, and calcification. So as a consequence, as we were saying, if this happens to coronary artery, it will cause myocardial infarction. Here you can see this heart. There is a part which is a dark. It is just to show that it is necrotic already. In the brain, there is a cerebral infarction here, which is dark, and the gangrene of extremities. So can have also abdominal aortic aneurysm here. And as I said the last time, it usually happens just above the bifurcation of aorta into these femoral arteries. So it is just a fact. So nobody knows why it happens usually there. So I remember when I was working in the district hospital, I was just doing, I don't remember if it was a cesarean section or another surgery. So when I was just palpating, checking if I have removed the gauzes, biriya bitambaro umuntu aba yahanaguza ariko baga. So I felt a mass behind the peritoneum, so retroperitoneum. So yeah, and it was pumping uko umutima utera nayo ikagenda itera. So then I said this should be an aneurysm. Of course, kubera ko yari inyuma, I could not go there. Niyo nsanga rero nta kintu ari kuyikoraho. That is an advanced surgery I could not do. So then I continued to do what I had to do. Then when the patient was fine, after surgery and the discharge from hospital, I referred her to the teaching hospital to see for them to see if it was really aneurysm and then decide what they can do. So ischemic heart disease is a common health problem, especially in the developed countries. But when you say in the developed countries, it doesn't mean that we don't have them here. So we may have them here, but we don't know the extent of them, because aba ni abarwayi bakunda gupfira mu rugo, bamwe bavuga ko barozwe, rimwe na rimwe bavuga ko bishwe n'ibindi, cyangwa se ibintu byinshi. So akenshi aho bapfira aho ngaho bagahita bashingurwa ntawe ubimenya. Cyane cyane ko na mbere ari umuntu usanganywe ibintu arwaye ntibivugwe, ntiyivuze. So ibyo byose birahari. Bituma rero imibare yacu iri hasi. Ariko nanone n'ubundi ntibuza ko abantu bemeza ko muri developed countries aho ibi byiganje, kubera ni za ndwara ziterwa na urban lifestyle zituruka kuri obesity, kurya ibintu birimo fat and so on. Bya bindi the risk factors for atherosclerosis. So birumvikana ko abantu wenda bakora imirimo y'amaboko, bagenda n'amaguru hanini, ahantu hanini n'ibindi, cyangwa se bakora siporo n'ubwo bari mu mujyi, risk zo kubigira ziri hasi. Bituma abantu bo muri rural areas of Africa, for example, aho ugenda n'amaguru ugiye gukora amasaha n'amasaha buri munsi, risk ziragabanuka, batarya na fat nyinshi. Ariko nabo bafite izindi risk factors zabo ku ruhande, wenda ibintu barya bidatunganye and so on. So it causes high mortality and morbidity. Iyo ubonye nka imibare igaragaza impamvu zitera impfu ku isi mu bantu cyane cyane bakuze, izi ni indwara za mbere. Coronary heart disease is among the first one, more than cancers even. So etiology, as I said, that the most common is atherosclerosis. So we have two major types: angina pectoris and myocardial infarction. I think I have explained in a few summary the difference. Angina ni yari ischemia and not yet necrosis. When necrosis is there, it is myocardial infarction. So we have risk factors: hypertension, hypercholesterolemia, diabetes mellitus, smoking, lifestyle, as I was saying, in the diet and the genetic. Also, there are some people who are disposed to have this. Ku buryo niba afite risk factors, ari exposed risk factors kimwe n'undi, uyu nguyu we aba afite agira ibyago byinshi, cyangwa abangaba bafite genetic predisposition, nubwo baba exposed nk'abandi, ariko bazadevelopa iki kibazo kurusha abo bandi. So, and I think most of these things they can be checked or screened. So kumenya ko umuntu afite hypertension, ngira ngo no muri community bakunda kubikora, even in the churches, in the church I belong to. So they used to have these campaigns, medical camps and so on. Bagapima abantu umutima, bakapima diabetes. Hypercholesteremia ni ibintu ku bitaro bapima cyane cyane teaching hospital, district hospitals I don't think we do. So otherwise ibindi ni lifestyle urebe inyuma. Genetic of course we do not know, uretse kureba muri famille, ndavuga iyo muhuje amaraso, tuvuga iyo washatsemo cyangwa iyo uzashakamo, iyo muhuje amaraso niba iki kibazo gihari, then you take more measures. So ischemic heart disease, as we know, is caused by ischemia, which is diminished transport of oxygen by the blood. So hypoxemia, hypo, it means decreased, oxygen emia in the blood. So diminished oxygen in the bloodstream. So that's the meaning of this word. But this is less deteriorous than ischemia. I think you have seen this in a cell injury. Why? It is because when there is the ischemia ni ukuba umuntu yabuze amaraso muri rusange, ntari kugera ahantu muri tissues runaka. Naho hypoxemia ni oxygen gusa. So impamvu ischemia ariyo mbi kurusha hypoxemia ni uko muri ischemia kubwa na hypoxemia birimo. Niba amaraso atagerayo ni ukuvuga ko na tissues zitari kubona oxygen. Uretse oxygen na nutrient ntizigerayo. That's why ischemia is more deadly than the hypoxemia itself. So ischemic heart disease sometimes is called also coronary artery disease or coronary heart disease. So in an abbreviation, CHD, CAD, or IHD. So or these abbreviations, we will be seeing them. So they are almost the same things, difference. So ischemic heart disease, ntabwo ari indwara ubwayo. It is a syndrome. There are syndromes. So syndromes means it is like a set of diseases or diagnoses which have some signs and symptoms in common. So murabizi iyo bavuze ngo malaria syndrome, ntabwo bavuze ko afite malaria, ahubwo bavuze afite ibimenyetso bihureho n'indwara zirimo cyane cyane malaria. So umuntu ufite grippe, umuntu urwaye typhoid, umuntu urwaye malaria, abo bose bafite malaria syndrome. So as a doctor, when you will be diagnosing disease, usually you start with syndrome. So you say this patient has fever, has nausea, has vomiting, and maybe other signs, and diarrhea. So in conclusion, you say this is a malaria syndrome. So mu gifaransa twabitaga syndrome paludisme. So paludisme ni malaria. So say malaria syndrome, but you don't stop there. Now, when you have that syndrome, you do investigations in order to reach the final diagnosis. So if you have a malaria syndrome there, what will you do? You will test for malaria. The test we will do is good test, and everywhere even in health centers it is done. And you do other tests such as Widar test for. Sorry. So you do Widar test for typhoid fever and so on. So no, if you are negative, you rule out the diagnosis until you get the final diagnosis. So the cause in most of ischemic heart diseases, 90% of the cases are caused by atherosclerosis. So as you have seen, you have 4 types of ischemic heart disease. As I said, this is a syndrome, but in it you have 4 different types. So these ones, they are now diseases or diagnoses. So myocardial infarction, sudden cardiac death, angina pectoris, and chronic ischemic heart disease with heart failure. So these are the 4 main types of ischemic heart disease. So the acute coronary syndromes, but there is someone who's talking. If you have a question, you can ask. Otherwise, you mute your microphone. So the acute coronary syndrome, it means they look like ischemic heart diseases, but they are acute. So you remember the difference between acute and chronic. They are acute because of the acute symptoms. So there's the abrupt onset, very intense pain, and so on. So in them we have acute myocardial infarction, unstable angina, and sudden cardiac death. So we will come to details after that. So I think in atherosclerosis you have seen that for ischemia to be symptomatic or to cause to have signs and symptoms when someone has ischemia, the vessel has to be occluded at to 75%. So no kuvuga caliber of the vessel will be occluded to this. When it is more than 75%, these are symptomatic even at rest. Otherwise, iyo igeze kuri 75 kw'ijana, azagira symptoms mu gihe akoze exercises cyangwa mu gihe ateruye ibintu, so mu gihe akoresheje imbaraga nibwo uzaba symptomatic. Otherwise, ubundi umuntu azaba symptomatic even at rest, igihe stenosis, igihe vessel izaba yifunze kugera kuri 90%. So gira ngo pathogenesis birumvikana nibyo twabonye muri atherosclerosis. We don't have to go into that again. We will read it. So this is a normal vessel. So we consider this is in a coronary artery. With atherosclerosis, you see that the caliber has decreased in its size because of this atherosclerotic plaque here. So this is the fixed coronary obstruction, and it can cause typical angina. Where you have read this, typical angina and stable angina and so on, the differences between them. So the symptoms can happen in either if the size of the atheroma has increased very much, and kubera ko iyi size yongera gake gake ntabwo ari ikintu cyakura amakanya gato, unless has complications, bizakura gato, icyo gihe azagira chronic ischemic heart disease kubera ko hazagenda hifunga gahoro gahoro. Ahangaha ntabwo hifunga gahoro gahoro, niba agize thrombus formation izaza vuba vuba. If there is a disruption and thrombus and so on, ibi ni ikintu kizaza, niyo mpamvu hano azagira acute coronary syndrome itandukanye ni chronic ischemic heart disease. So the syndrome in this ischemic heart disease, we have stable angina. So niyo stenosis yageze kuri yarenze 75%, ntabwo afite plaque disruption, nta nubwo afite thrombus or any other complications of atherosclerosis. So iki gihe ni stable angina with a stable kako azagira ibimenyetso igihe gusa akoze exercice physique cyangwa se ateruye ikintu kimusaba ingufu icyo aricyo cyose. So unstable angina yo stenosis ishobora no kuba ari gato cyane, ahubwo ni yindi izaterwa nuko yagize plaque disruption with or a thrombus, but which is not occlusive. Kuba occlusive, automatically ahitagira transmural myocardial infarction. Ntabwo azagira angina, azayigira kanya gato mu minota mike ubundi ahitagira myocardial infarction then up. So ahangaha rero murabona ko uretse stable angina, izindi zose ziterwa nuko habaye changes muri atheroma. So either plaque disruption or a thrombus itself. So sudden death ishobora kuba mu gihe umuntu agize severe stenosis. Ira stenosis nubwo twavuze ko iza gahoro gahoro wibwayo, ariko rimwe na rimwe ishobora kuza rimwe kuri rimwe bitewe n'impamvu, kubera psychological issues zishobora gutuma haba vasoconstriction, cyangwa se imiti cyangwa ibintu umuntu ariye cyangwa anyoye bishobora kuba bitera vasoconstriction. So nako kanya ahangaha yahita agira stenosis ako kanya kandi agahita. So that's why it is called a sudden death. So sudden death in forensic medicine ni ukuvuga iyo umuntu apfuye hatarenze amasaha 24 atangiye kugira ibimenyetso by'uburwayi, bayita sudden death. And usually it must be handed to the police cyangwa ubuniri investigating iki kibazo until a medical doctor will confirm it was just a sudden death, maybe caused by coronary artery disease or any other issue. So angina pectoris, the signs and the symptoms are chest discomfort, umuntu aba aribwa mu gatuza inyuma ya sternum. It is prolonged, recurrent, and of different qualities. So qualities ni kumwe avuga hari umuntu uribwa yumva ari nk'ikintu kiri kumukanyura, so nk'ikintu kiri guhotora cyangwa nk'utewe icyuma. So these are qualities nicyo bashaka kuvuga of pain. So the cause is the transient myocardial ischemia, which takes a second to minutes, ariko bakunda kuvuga for the heart iyo birengeje 20 minutes itabona amaraso cyangwa oxygen, already the myocardial infarction takes place. So the angina pectoris itself can be stable or transmittal or unstable. So is stable if there is the blockage of the caliber is at 75%, and usually this angina pectoris will be transient, less than 15 minutes, but it can be aggravated by exercises and relieved by rest and nitroglycerin. This is a vasodilator, VD. So ni umuti utuma vessel iba dilated. So ibi ni ibintu by'ingenzi mugomba kumva. So for Prinzmental angina, it is caused by coronary spasm. Spasm ishobora kuba psychologic, ishobora guterwa n'ibindi and so on. Episodic, typical ECG change. So electrocardiogram. So ngira ngo mwarazibonye tuntu tugenda twishushanya ku gapapuro, hanyuma bitewe n'uko umurongo wagiye bagasoma ko bati afite ikibazo kuri ST cyangwa kuri Q and so on. So and it is relieved by VD but not rest. Unstable angina, it will be that if there is the vessel blockage is at 90% or more, or there is acute plaque change, and it's as in the traumas and rupture and so on. It is prolonged more than 15 minutes. It is not relieved by rest, by vasodilators, and usually this is considered as a pre-infraction angina. So no kuvuga ko akenshi ayifite ahita ajya muri infraction. So ngira ngo ahangaha rero duhari murabona ko mushobora kuba mwarabyize, hari igihe ukora diagnosis bitewe n'uko umurwayi umuti wamugiriye akamaro. Ni ukuvuga ushobora gukora ahantu ukavuga uti ndakeka ko ari malariya cyangwa se ikaba ari typhoid, ni urugero niba afite syndrome ya malaria. So icyo gihe ukavuga uti for me to know diagnosis, let's start with malaria treatment. Nta test nimwe ushobora gukora, ukamuha coartem ukabona ntacyo bitanze, ukamuha antibiotique zishobora typhoid, ukabona zo uzimuhaye atangiye koroherwa. So that in that time you can now confirm the diagnosis was typhoid fever. So icyo mbivugiye ni iki, nuko ahangaha uyu muti nitroglycerin hano nubwo uvura ari vasodilator ariko unagufasha gukora diagnosis. So nukuvuga ko ufite aho waba uri hose ushobora gukora diagnosis of these three subtypes of disease of angina pectoris. Because ahangaha niba umubwiye ngo ryama uruhuke ukabona arorohewe, cyangwa se ukamuha nitroglycerin niba ari umuntu uko ameze wenda ntashobora, hari igihe aba ari agite udashobora kuvuga ngo ryama uruhuke kubera uburyo ari kuribwa cyangwa uburyo asanzwe ari agite, icyo gihe ntabwo ashobora kuba muri resting condition, icyo gihe wamuha nitroglycerin ukabona they respond. So ibi byose bishobora kukwereka ko yari stable angina. Ariko niba hano bishoboka ko umubwira ngo aruhuke akanashobora kuruhuka bikanga akomeza akaribwa, ukamuha vasodilator ukabona nibwo aruhutse uzemeza Prinzmental. Niba byose byanze ushobora kwemeza ko ari unstable angina, bityo ukanababwira uti byerekana ko ashobora kugira infection, kandi myocardial infarction usually means death niba atari ahantu atari hafi y'aho bashobora kugira icyo bamumariye. So these are things you can combine and get the final diagnosis. So myocardial infarction, it can be transmittal, no kuvuga ifata full thickness cyangwa se igafata agace gato nk'hano yafashe inner third or half of the ventricular wall and near the endocardium. So this is subendocardial myocardial infarction, where this is transmittal myocardial infarction. So, and the causes here and the consequences you have read there. So myocardial, so ahango twarebaga angina pectoris hariya muri rusange, so ahanga tutangiye myocardial infection ubwa. So ngira ngo icyo mugomba kwitanga nuko hari abarwayi baza baribwa mu gatuza rimwe na rimwe ukaba wakeka ngo ni angina pectoris afite. So ngira ngo story niyeze kubabwira when I was doing internship ku bitaro bya Ruhengeri, so nakira ari nijoro umuntu wigaga kuri la shuri yari ikiri ira campus ya Busogo, cyo gihe yari ikiri ishuri rya kaminuza kwa cyangwa institute kwa. So she was complaining ko aribwa mu gatuza, aravuga ngo arumva ari umutima umemereye nabi. Andabara ariko nuko yukinisha indwara z'umutima baba ufite angina pectoris ngo we bakuvanye iriya bakugeze hano nyuma y'amasaha itara infection, kandi iyo infection ntabwo uri kunyeganyeza agatoki. So it was just a gastritis with ulcer. So birashoboka ko umuntu agira stress akagira ulcer mu masegonda makeya then akaribwa. So nicyo kibazo yari afite, ariko kwa ko umutima uturanye n'igifu birumvikana hari igihe kimwe gishobora kwitiranwa n'ikindi. That's why you have to be very careful when you take a history of the patient. You have to be deep in history and also to be thorough in your clinical examination. So myocardial infarction, it is a disease most of the time for the old people. Ariko I think things are changing kubera stress abantu baba mu iki gihe. Myocardial infection cyangwa se na heart infection ndetse na stroke ubwazo biri kugaragara n'abantu batoya. So we have to be careful. So in young people it happens. So 10% of myocardial infarction patient they are in 40s, while 45% they are at least age 65 years and more. So males are more affected than females, although physiologically or pathophysiologically to explain this is not known. Maybe also it is because atherosclerosis is more seen in the males than females. So ethnic or racial differences known between American whites and the African and the American Africans. So murabizi rimwe na rimwe muri iyo badashaka kuvuga amoko, iyo bashaka kuvuga birabura bo muri Amerika bavuga Americans cyangwa se American Africans. Shaka kuvuga birabura bo muri Amerika bashaka gutandukanya n'abanyamerika b'abazungu, so batashaka kuvuga birabura n'abazungu, so bavuga Caucasian Americans and African Americans. So risk factors major modifiable are diabetes mellitus, hypertension, smoking, hypercholesterolemia. Nizo risk factors cyane. So they are modifiable kubera ko nubwo izo ari indwara ubwazo you can control them. So pathogenesis, usually it is caused by coronary vessel occlusion, with atherosclerosis being the most common, and the vasospasm in other 10% cases. So the most important mechanism is the dynamic changes in the plaque. It's a rupture, thrombus, and so on. Nibyo bibitera kurusha plaque y'ubwayo uko ingana. Nyango twabibonye kwa ko iyi plaque ikura gake cyane, ntabwo rero yatera myocardial infarction, ntabwo ari kenshi yitera, ahubwo iterwa na zira changes, disruption and so on. So irreversible changes will happen after 30 minutes of ischemia. So this is arbitrary, of course. This is arbitrary. Haravuga 20 minutes and 30 minutes. And I was like 2 weeks ago discussing with some medical doctors. So buri wese atanga experience y'igihe umuntu yapfuye bakamureyanima, ubundi bavuga iyo irengeje iminota 30 ureyanima umuntu ugomba guhagarara. Iyo ubona resuscitation nta kiri kugeraho atongera kubaho, kandi nyine bigaragara ko yapfuye, umutima wahagaze, mukakora wenda massage mukamuha imiti za adrenaline n'ibindi, iminota 20 cyangwa 30 igashira urekeraho, kubera bagendera kuri ibi ngibi. It is because after 30 minutes the heart without receiving blood it is already dead, myocardial infarction, ubwonko bwo buba bwapfuye mbere, just 4 minutes. Ni uko theory ivuga. So as I was saying, then we are discussing with these other doctors, so they are saying buri wese aratanga ingero. Hari n'urugero rwatubayeho ku bitaro aho umuntu he collapsed, umutima urahagarara, ibintu byose byumvikana byahise bihagarara no guhumeka, ariko reanimation imara amasaha arenga 2. Then okay, bajya guhagarika umuganga umwe akaba ati njyewe umutima ndi kumva uri guterana cyane, mukomeze. Ariko anavuga ntabwo turi kubumva, so reka dukomeze turebe. Hanyuma biza gutwara amasaha arenga 2 umuntu aza umutima unongeye urakora, bamujyana muri intensive care. So ikibazo umuntu wese yibazaga ati none se okay, dushimye ko umutima wongeye gukora, biragenda bite ku bwonko ko burabwa amaze kwangirika? Nuba ko azaba ari umuntu w'ikidebiri uraho ngaho. Ariko igitangaje, mu nyuma y'icyumweru cyangwa ibyumweru 2 yasubiye mu kazi, atwara imodoka, nta nubwo no kwigeze agira ikibazo. So bigaragaza ko iminota 30 cyangwa 20 ivugwa ni arbitrary nk'uko nabivuga. So n'undi yatanga ingero, abana yagiye agira akareanima amasaha 2 cyangwa 3, nyuma akongera akabaho, kandi ntibabaye debile, bariga neza nk'abandi. So niyo mpamvu uvuga ko tubiganira, ndetse ushize ndi kwigisha abanyeshuri bo muri plastic surgery, twari tuganiraho, umwe muri bo aravuga ngo so they are postgraduate, aravuga ati jewe mumbabarire mubimenye, igihe nzagira ikibazo nk'iki njye muzandeyanima amasaha nibura 5. So yahise abivuga kubera ibyo twari tudiskita. So bivuga ko ntabwo bivuga ngo nugira umuntu uzamureanime iminota 20 urekeraho kubera ko ibitabo bivuga. So it will depend on many factors. Of course hari abarwayi bitari ngombwa kureanima, niba umuntu wenda yararwaye cancer ari muri end stage, ubundi byagenda bite. So ibyo byo biba byanditse muri there are indications of doing resuscitation or not doing so. So you will judge as a human ufite ubumuntu, and as a medical doctor, as a scientist. So mechanism of death is coagulative necrosis. So niki rero ushobora gukora nko muri surgery cyangwa se autopsy gishobora gutuma uhita wemeza ko umuntu agize myocardial infarction? Nuko yo when you do section ushyiraho this is a stain, ni ikintu gusa usigaho, ni akantu k'umuti usigaho, ukareba iyo hakomeje kuba brown aho haba ari hazima. Iyo herurutse ni ukuvuga ko iyi ni tetrawat, it is a wrong name, ngira ngo mwarabibonye muri notes hano irimo. So iyo hatabaye brown, aho hantu habaye infection. So nicyo kimfasha kubyemeza. So ni triphenyl tetrazolium chloride, TTC. So it detects and stains the mahogany brown with lactate dehydrogenase. So LDH muzi ko banayipima mu bitaro henshi, nk'umuntu afite ibibazo runaka, umutima, umwijima n'ahandi bakunda kuyipima. Igiramo na subcomponents, hari iyo bagiramo iy'umutima, hari iy'ubwonko, hari iy'umwijima, biterwa n'iyo ushatse gupima. Ariko iyo babwiye ngo mupime LDH gusa, bo bapima muri rusange muri labo. So iyi enzyme rero ibiri muri a healthy muscle, aho itari rero ntabwo hazaba stained kubera ko enzyme itagihari, kubera ko hamaze kuba infected. So niyo principe yo bituma koresha stain. So on a right microscopy, kuri microscope bazanye tissue, iyo mu masaha 12 ya mbere nta kintu ubona, ariko hagati y'amasaha 12 n'iminsi 3 you see coagulative necrosis with many neutrophils. If it is more than 1 week, there will be granulation tissue. If it is more than 3 weeks, a fine scar, and so on. So this is important, for example, in forensics. it can at least not only forensic, even in a clinical autopsy, it can tell you that this person had an acute myocardial infarction because niba apfuye akanya bagahita mumukorera ibingibi histology ugasangamo no changes, uzamenya ko infection yari ije vuba. Nusanga imaze yaragize scar, uzamenya ko yari afite chronic ischemia, amase yagiye apfa gake gake. So that's how these things can help. Ariko muri forensic ibi byose bifite akamaro, kumenya amasaha yapfiriye ni nyuma y'igihe kingana iki yari yagize ibibazo, so ibi byose bigira akamaro forensic. So one day or the infarct, so we have a wavy fibers and a few inflammatory cells. Anga inflammatory cells ziyongere ubu tumona tw'umukara, they are nuclei of neutrophils. In 1 or 2 weeks to have a granulation tissue with a few blue fibers, and here we have more blue fibers. This is a scar. So it can be reperfused, and this you have seen in a cell injury. Ikibazo cya reperfusion yango nanakigarutseho ubushize gato muri healing and repair, nuko iyo habayeho tissue necrosis hakabaho reperfusion. Ira reperfusion ikibazo cyayo nuko iyo yinjiyemo amaraso akinjiramo, mu kwinjiramo vene irongera igafata n'amaraso ikajyana mu yajyana hageramo free radicals nyinshi. Izi free radicals rero ziteza ibibazo byinshi yango. That's what we had to say. So but reperfusion ushobora kumuha imiti nka thrombolytic drugs. Niba ari thrombose yateye ko amaraso atagerayo, yaje muri ko nayo tari kama thrombolytic drugs zizashwanyagurika hanyuma amaraso akomeza. So thrombolytic drugs zirahari aho uri hose. Aspirine n'umwe mu miti iri thrombolytic. Umwe mu miti iri thrombolytic ishwanyaguza. Of course ntabwo ifite imbaraga nyinshi, hari indi miti ikomeye. Hari n'iyari muri clinical trial muri research yari mwigeragezwa. So ntabwo research ni mu bihugu byinshi ku isi, harimo na CHK yakorerwaga mu bihugu nyanga birenga 100. So haba hari imiti myinshi ifite imbaraga ariko ikoreshwa bitewe na indication. So this is showing the region of perfusion defects ahanga ku mutima. So baragaragaza, so niba wongeye utanze reperfusion mu minota mike itarenze 20, amaraso akaba yakongera akageramo, ari kiriya gice cyari cyabaye ischemic ntabwo ari necrotic, ntabwo ari infarct, cyari cyabaye ischemic, kizongera kiba reperfused, wenda hasigara agace gato ko hagati aba ariko kakomeza kutagira amaraso kubera ko kagize kabaye damaged, habayeho necrosis. Niba reperfusion ikozwe mu masaha atarenze 4, nabwo hazaho partial salvage, ariko byumvikana ko umutima icyo gishobora kongera gukomeza gukora, hakabaho ngira ngo I didn't interpret well, viable. Yeah, this is also viable, it is not necrotic. Necrotic, it is this one in the partial salvage. If there has been a permanent occlusion, nukuvuga reperfusion yananiranye burundu, cardiac massage mwakoze byanze, so hazabaho complete infarct. So aho ngaho niho hazakorwa izindi intervention. So silent myocardial infarction iterwa cyane cyane diabetes mellitus, hereditary cardiac transplantation recipient and so on. So nukuba ko umuntu ugira myocardial infarction ariko ntagira ibimenyetso, akenshi ntabwo yafashe zone nini, ukurure yabaye mu tuveso duto cyane. Muzi ko diabetes mellitus nubwo igira effect kuri all vessels, ariko yibasira very small vessels kurusha larger vessels. So maybe that's why here this patient will have a silent myocardial infarction, as I infarct duto cyane tubuze umutima gukora, tutanamurya, so on. Ni kimwe n'ubwonko haranubwo ukorera scanner cyane cyane bakuze bagasanga agira stroke duto nta kimenyetso yigeze agira, ntiyigeze ataka, wenda ataka umutwe kagira ngo ni bisanzwe. So nuko tuba twarabe duto. So kuba rero umuntu atarigeze agira paralyze cyangwa ikintu biva hati ya stroke. So the diagnosis, the best markers in troponin T and I, and they are sensitive and specific. Hari noneho n'izindi ahangaha. So predictive CRP, C-reactive protein, cyane cyane ni ipimwa mu bitaro byinshi, ireba ko umuntu yagize inflammation. Usually it is not specific, this one. So complications of myocardial infection harimo byinshi. Arrhythmia, no kuvuga umutima utera irregular, rimwe ukagira vuba vuba. This is fibrillation. Iyi fibrillation yibwa akenshi ituma umuntu apfa. Fibrillation uvuga umutima uratera ukajyaho ugasa n'ugagaye nk'ufashwe n'amashanyarazi kubera gutera vuba vuba. So pap failure, this is left ventricle failure and so on. Ventricular rupture, true aneurysm, and rupture, it can rupture, pericarditis, and recurrence. So arabagira myocardial infection bakavurwa bagafashwa aho bishoboka, hanyuma akazongera akagira indi. So the sudden cardiac death, okay, hano bavuga unexpected death in 1 hour due to cardiac causes with or without clinical symptoms. So I have said the 24 hours. Here there's the 1 hour. So causes are atherosclerosis. So kuri electrocardiogram ubonamo ko harimo QT, long QT segment, and then ikindi kibazo agira potassium in the sodium pump defects will be there. So mechanisms, usually it is caused by ventricular fibrillation, arrhythmia. So nkuko navuze arrhythmia cyangwa fibrillation akenshi itera sudden death. So ikunda kuba kuri young athletes, abafite pulmonary hypertension cyangwa se abari basanga ischemic heart disease. So ngira ngo hagaha kera turi kwiga medicine hari umukinnyi wa yangwa kinaga Cameroon, ntabwo nzi imikino bari barimo niba ari igikombe cy'isi cyangwa cya Afurika, ntabwo nibuka, ariko yaguye mu kibuga yitwaga Mark, niba ari Fue nk'ibyo, yaguye mu kibuga, so basanze ari ibibazo yagize. So there are morphology prominent findings is increased heart mass, umutima uzasanga ubundi wari ubyimbye, and so on. Facioration in the subendocardial myocardium. So the chronic ischemic heart disease, I know it is ischemic cardiomyopathy patients, especially ni ababa barakiriye umutima as a transplant, uvuga umutima. So transplant ni ya kidney, uziko cyangwa muri bise mu Rwanda bagiye gutangira transplantation of the kidney, ariko kimwe mu bibazo byayo nuko organe yakiriwe nubwo amaraso ayijyamo, ariko akenshi ntabwo yakira neza. Ntabwo nko ku mpyiko n'ubundi umuntu bayimwakiri mutoya ntabwo ashobora kuzamara imyaka myinshi akifite ya mpyiko. Nyuma y'imyaka 10-15 bagomba kumuhindura akabona indi kidney. Where to try ischemia tugenda tuza. So the same to the heart. Because of the ventricle cause compromised ventricular function, morphology, vacuoles, myocyte hypertrophy, and this is diagnosis by exclusion. So diagnosis by exclusion in diagnosis ugeraho when you exclude all other possibilities. Ngabya bine navuga kare, uri umufite umurwayi afite malaria syndrome, ugakora test ya malaria kuko ushobora kuyikora ugasanga ni negative, ukaba udashobora gukora test ya typhoid kandi ariyo yindi diagnosis yari isigaye, icyo gihe uzayemeza, but uzayemeza as by exclusion. It is not because you have tested it, it's because you have excluded other possibilities. So Sarah, so I think from here now we go to the endocardium. So izo twareba cyane cyane ni nka myocardium ubwayo cyangwa zera the ischemic and the ischemic disease itself. So next we'll go to the other layers. So now we focus in the myocardium. Now we will go to the endocardium and then pericardium. Any questions so far? So we can have just a small break, 7 minutes break, and then we resume.
biraje. Ko bitavuga harimo ikihe kibazo?
Personally,
Ariko
unmuted.
yagiye
Unmuted. Ushobora kuba atagiye gihari.
Niko turi muri break.
Crispus, Concordia, Delphi, Emmanuel, Sigismund, Eternel, Anis, MH, Nadine, Remy.
Okay, so this break is over, 8 minutes, so we can proceed. So I hope you can see the screen again and hear me. So it is not shared. It's great. So you see it, the screen or not?
Yes, we are seeing the screen.
Okay, thank you. So we go to other areas of the heart. So for inflammations, we shall see endocarditis and pericarditis and myocarditis, but the most common one is the endocarditis, as I said when starting. So, and the most common is the rheumatic fever. So we shall see some other examples, and the other infections, non-infective. We have two main ones: non-bacterial thrombotic endocarditis and the endocarditis of systemic lupus erythematosus. This is a syndrome. So systemic lupus erythematosus ni syndrome, ntabwo ari indwara, ntabwo ari a disease per se. Igaragazwa cyane cyane n'abantu so muzi ko muri apoptosis the materials from the dead cells, they are enveloped in a membrane, what we call apoptotic bodies, and there is no leakage of the cellular content to the environment. Ibyo bituma hatazaho reaction. There is no inflammation after apoptosis, but after necrosis there is always a reaction. But in these people with systemic lupus erythematosus, the issue is that when there is apoptosis, there is a leakage of DNA. So the packaging of the materials from dead cells is not well done. So there is a leakage of DNA and other contents to the surrounding areas in the organs, and because of that, there will be a chronic inflammation. So the body will react against its own components, DNA mainly. So uzasanga no muri laboratory bapima anti-DNA antibodies. So bapima antibodies z'umuntu zirwanya DNA ye, nizo bapima kwemeza ko afite systemic lupus erythematosus. So no kwibahurira. So it can affect any organ. Ikunda kubabariramo bwa mbere y'izindi ni kidneys, hagiramo nephrotic syndrome kubera glomerulus zashwanyaguritse and so on. Ariko most of the other organs are affected, including the skin, including the heart and so on. So carcinoid heart disease iterwa wenda tuzayigarukaho cyane muri presentation on the gastrointestinal tract. nawe ndadushobora kuza kwigarukaho. So for the infective endocarditis, birumvikana ni inflammation of the endocardium, which is caused by infection. So the causes can be bacterial, fungal, rickettsial, and chlamydia. Cyane cyane iyo bavuze endocarditis, prototype ahantu ifata bigakunda cyane cyane ni valves. Ko valves ikozwe na endocardium ubwayo. So ahandi ku bindi bice bisanzwe bya endocardium imbere, iyo hayo region, yeah, it can be there, ariko consequences ntabwo ari nyinshi nk'igihe valve yari yangiritse. Niyo mpamvu twibanda kuri valve. So bacterial causes, they are listed here. Staphylococcus, streptococci, and HASSEC, which is abbreviation of Haemophilus, Actinobacillus, Cardiobacterium, Echinacea, Klebsiella, and so on. Gram negative bacilli. So the predisposing factors for infective carditis is rheumatic heart disease, myxomatous mitral valve, calcific valvular stenosis. It means there is a stenosis of the valve. Nuko valve yabaye nini, yabyimbye, bituma ifunga, iranzira amaraso yanyuragamo, rimwe na rimwe akazamo calcifications. So bikunda kubibona iyo babanze valve z'umuntu, akenshi iyo isuzumye usanga harimo calcifications. So we have other risk factors. So there will be vegetations of fibrin. So vegetations nubwo bazita gutya n'ubundi iyo uzireba kuri wenda kuri autopsy and so on, ubusanga ari utuntu tumeze nk'uko shufureri ikura, donc ari ibintu biri irregular nk'uko shufureri imeze, or cauliflower. They are located on the heart valves, as I said, mostly on the most important. Okay, all the valves are important, but when the aortic valve and the mitral valve are damaged, niho biteza consequence nyinshi kurusha uko right-sided valves zaba zangiritse. Vegetation may erode or perforate valves. Birumvikana, if the valves are eroded or perforated, regurgitation of the blood will take place. So they can produce emboli, and this will produce a septic infarct in the brain. So you understand now, an embolism which is composed of just blood clot, it is one thing. But when it is composed of bacterial things, you can imagine if just a mass of bacteria reaches the brain, what will happen? There will be a severe inflammation, infection. So this is the valve. This is how it appears. Nuko ibimeze, so ni nk'imigozi isobekeranye myinshi, ariko kaba gafunze buryo nta maraso atambukamo igihe bitari ngombwa. But here there has been infective endocarditis with perforation. So ahantu banyujije agati bakajomye habayemo perforation, and in these vegetations which are irregular. So, and this is just a mitral valve itself. So it has vegetation. So this is on histology. These blackish dots you are seeing, they are nuclei of inflammatory cells. So the clinical signs, there are fatigue, chills, weight loss, flu-like syndrome, or malaria-like. Murmur may change as vegetation and or damage to the valve changes. So murmure, mu gifaransa murmure ni ya valve, ni ukuvuga igihe uri gukora auscultation wumva ko umutima uteye, ariko hagati yo gutera no kundi gutera gukurikiye ukumva harimo ibintu biri kugenda nk'amazi ari kugenda. Ibyo bisobanura ko hari amaraso ari kugaruka. So it is a sign that there is a regurgitation of the blood. Icyo gihe ubundi hagomba kuba hacecetse, ariko yumva hari muvoma y'amaraso nuko haba hari ikibazo. So non-bacterial thrombotic endocarditis birumvikana ni inflammation, but which is not caused by bacteria. So It is sterile because no bacteria. So you receive vegetation of fibrin, platelets, and other blood elements. So usually it is a consequence of hypercoagulable state. You remember virtual triad, hypercoagulability status and endothelial injury, and the blood flow. Ibyo bita tubitera triad of virtual. So one of them is the hypercoagulable state. So it will just, the blood will be stagnant there and induce inflammation there, probably because there are some blood clots which have attached to the endocardium. So basically, endocardium, what it does, it is like what the endothelium does. Whenever there is a lesion on it, automatically blood clotting will take place. So local effect on the valve is not very important. This one may produce emboli and infarct somewhere. So endocarditis of systemic lupus erythematosus in Riemann-Sachs endocarditis. So if you are asked what is Riemann-Sachs endocarditis, it is a type of endocarditis which is caused by systemic lupus erythematosus. Also, it is sterile. SLE, there is no bacteria. Instead of bacteria, we have antibodies against their own body. So it is an autoimmune disease. So here, for example, there are antiphospholipid antibodies. So phospholipid, these are mainly seen in cell membranes. So if there's a apoptosis, a leakage of DNA, but also leakage of components of the cellular membrane, our body will make antibodies against all these things. So you can measure these antiphospholipid antibodies in the blood. So the vegetations are small. There are granular fibrinous eosinophilic material. Valvulitis means the inflammation of the valves with fibrinous necrosis. Also, fibrosis can happen if the inflammation has been there for a long time, and this will cause the valve deformity. Akazagira ibimenyetso bimeze nk'ufite chronic rheumatic heart disease. So these are people who need to undergo surgery. Akenshi basimbuza valves zabo, byo ntabwo ari surgery zigorana nk'uko wenda gusimbuza umutima bimeze. So ahantu nka Dar es Salaam naho barabikora gusimbuza valves. Most of the day they do it. So carcinoid heart disease is seen in half of the patients with carcinoid syndrome. So carcinoid syndrome igizwe n'ibintu biri aha ngaho tuzabibona muri digestive system. So in a presentation I made yesterday, so we did some kind of details about this. So skin flushing, cramps, nausea, vomiting, and diarrhea. Ariko siterwa n'iki. We have tumors arising from neuroendocrine cells. So it means whenever we have endocrine glands, we can have a carcinoid tumor. A carcinoid tumor is a tumor arising from endocrine cells. So tuvuge ko inyinshi zikunda gukomoka muri pancreas, izindi muri stomach, because in the stomach we have endocrine cells. They're also secreting gastrin and so on. So when they make a tumor, then the tumors of the from these endocrine cells, they will produce substances or chemicals working like hormones, because these are endocrine. So iyo zikunda gukora cyane cyane iyo serotonin. So serotonin ikozwe rero of course as any other hormone izarekurwa ijye mu maraso. Niba ivuye muri stomach izajya mu maraso, izamuke muri liver, then bikomeza muri vena cava, then to the heart. Umutima noneho wohereza amaraso mu bihaha. So ikizwe rero nuko serotonin yigeze mu bihaha, ibihaha bifite uburyo bikora metabolism, noneho ntikomeze kuba dangerous. ntikomeze kuba dangerous because of the catabolism which happens to it. So, bituma amaraso avuye mu bihaha agaruka muri left heart yo nta kibazo aba afite. Uyu mutima uyohereje hirya no hino nta kibazo gihari. Niyo mpamvu mubona ko ibibazo byatewe ni carcinoid tumor biza kuri right side of the heart. Ni ukubera ko za chemicals nka serotonin zihagera zitaraba metabolized, zikaza metabolize ari uko zamaze kongera mu bihaha. So that is the meaning. Ni ryari carcinoid tumor ishobora kugira ikibazo kuri left heart? Byaterwa n'impamvu zimwe na zimwe, ariko bibaho gake. Ni igihe ibihaha byaba bifite ikibazo ntibishobore kumetaboliza ya serotonin, cyangwa se hakariho shunt between left and right heart. Bijya biho cyane cyane ku twana dutoya. Ngira ngo ni nabyo bibazo byinshi aho abaho communication between left heart and right heart, kubera hari uduporo tutifunga ku bana bamwe na bamwe, so bakazababaga bakadufunga. Icyo gihe rero amaraso arivanga ava muri right heart akajya muri left heart atabanje kujya kunyura mu bihaha. So I think here it is explaining the consequences from the heart, thickening of the muscle, thickening of the valves, and so on, and their consequences. So as I was saying, carcinoid tumors produce bioactive products, including serotonin and so on. Serotonin appear to induce the cardiac lesions, as I was explaining. And it is inactivated by pulmonary vascular endothelial monoamine oxidase. So it is what I was explaining. That is the reason why the left heart is not affected by this carcinoid syndrome. So apart from that, we go to myocarditis. Ariko icyo ngira ngo mbabwire nuko even in these two hospitals you can diagnose most of these diseases. Cyane cyane ko umwana afite rheumatic heart disease. So rheumatic heart disease wenda muzabyaga muri cardiology iterwa cyane cyane nuko umwana cyangwa umuntu mukuru agira infection yatewe na streptococci. Streptococci iyo cyane cyane zikunda gufata biriya bitwita angine bisanzwe, tonsillitis niho zikunze kuba zifata. So ikibazo rero, when someone has a chronic infection to that, a long-standing infection by streptococci in the tonsils, atangira gukora antibodies against them. So antibodies ubundi ntabwo yanabirwanya bacteria muri rusange, ahubwo antibodies birwanya some components of these bacteria. So it was seen then that some structures of these streptococci, they resemble the structures of our body, such as the valves, such as the glomeruli, and so on. Bituma rero umuntu ufite rheumatic heart disease akenshi aba yarayitewe n'izo streptococci yagize ntizivurwe akabihorana. Ikindi nuko n'izindi organs ziba zarafashwe. And so uzabona umwana aje yabyimbagatanye, nusuzuma wumve ko afite ikibazo kuri valves, ndafitemo regurgitation cyangwa mama muri valve, wenda mitral valve cyane cyane. Nubaza kubwira ko yatwaraga za angine cyane, bakamuha imiti y'ibyatsi and so on, bivuga ko atitaweho. So ibyo bizagufasha guhita umenya ko afite rheumatic heart disease yatewe na streptococcal infection and so on. So when I think I told you this story, when I was working in these hospitals, I remember I have 2 children I received and I treated. So we had a protocol. So ntabwo ari protocol twigiye mu ishuri, ni kwa kundi ucukumbura ugasoma ukamenya uko ibintu bishobora gukorwa. So that's why we encourage you to read, because you cannot be a good doctor with only our lectures. You have to be proactive and read, have a curiosity. So iyo protocol yasabaga ko yaba nubona umuntu umuhe antibiotic ikomeye cyane, the strong antibiotics against streptococci. So ni za penicillin zikomeye, uyimuha iminsi 10 injectable iminsi 10. So hanyuma nyuma yaho habyenseya n'ibindi byo gusapotinga umutima na za aspirine. Aspirine kubera iki? Nabivuze kare, irwanya thrombosis, kandi muri izi ndwara zifata valves haba harimo ritwe kwazamo twa thrombose dutera ibindi bibazo muzi. So ukamuha nk'iminsi 10 noneho ukamuha ukongera ukamuha extensiline, ni umuti uvura ziriya ndwara zindi sexually transmitted disease. I don't remember which one, niba ari syphilis cyangwa iki, ariko ni umuti batera muri intramuscular injection. So rimwe mu minsi 15. So protocol nuko yagomba kufata rimwe mu minsi 15 imyaka 5 yose. So kimwe mu bibazo bihari ni compliance y'abo barwayi, mbona ababyeyi babo, kuko waramubwira wahitaga umwandikira mu gakarine, baba bafite udukarine dutoya makayi baciyemo muri centre de santé zabo. So ukabimwandikira, then ntazirwa agaruka kwita, akazajya kuri health center bakamutera injection ibyumweru 2 ku byumweru bishize. So ava mu bitaro yatangiye koroherwa, akagenda wamutera amezi 2 cyangwa 3 akaba yakize burundu, ya miti bakayihagarika, kandi wamubwiye ni imyaka 5. So unfortunately ubu bose babiri bagarutse barazambye kurusha bwa mbere, bazaga barabyimbye amatama, amaguru, kubera ibibazo umutima baye insufficient, is no longer working as required. Uratera amaraso ariko agaruka, ndetse agomba kuza muri vena akava ntaze yose, so abyimbye ahantu hose. So bagaruka no barabaye deteriorated kurusha aho ngaho. So I was upset. So nta nubwo bari bazanye no kubyambayeho gutyo, so mbohereza muri teaching hospital because I could not start again. So maybe they sent them for surgery, but ariko ntabwo bashaka kumuvura bikiri gutyo. So ikibazo cyane nuko babona borohewe, ababyeyi bakishima, nisone imiti bakayihagarika, kandi baramusobanuriye neza. So icyo nashaka kuvuga nuko ni indwara ushobora guhura nazo muri district hospital, you diagnose it, you save lives, niba banakumviye bagacira burundu. Wenda yazagira consequence nk'izindi nka scar formation, aho niba bimuturutseho ni umubiri urwana gutyo, scar wenda bakazamubaga, ariko at least nta infection, kuba infection irimo ntabwo bamubaga n'ubundi. So this is a reality, nicyo nshaka kubabwira. And usually to diagnose this or handle these cases, you need the skills, you need the knowledge that usually you don't get from the lecturers or the lecturers. You need to be also proactive in knowing things. So for myocarditis, inflammation of the myocardium, they are immune mediated. It's a virus, akaba post-streptococcal, navugagaho nuko kudashfata valves gusisha no gufata myocardium, and so on. So other causes are sarcoidosis, giant cell myocarditis, and so on. So usually it will appear normal or dilated, and sometimes can be hypertrophic. Ventricular myocardium may be flaccid and have some hemorrhage. So flaccid itakora contraction ngo nikomeye. They can have a neurothrombi, nuko hazabaho blood clotting inside the wall. So these are microscopic features, common inflammatory cells such as lymphocytes, focal necrosis, giant cell myocarditis. Here we see mitochondrial giant cells here, like those ones we see in tuberculosis. So some are caused by Chagas disease. Chagas disease, which is a trypanosomiasis. So clinically, the patients will have fatigue, dyspnea, palpitations, precardial chest pain, fever, and so on. Some can be asymptomatic. And usually, if there is dilated cardiomyopathy, the heart failure will be there. Dilated cardiomyopathy, it means the heart, because the heart, it doesn't pump blood as required. Kana amaraso agakomeza akaza akitekeramo, yo irabyimba, ariko ntabwo habamo hypertrophy, ahubwo ni cavite ibyimba. Umutima ukabyimba regurgitation, arrhythmia, and other consequences. So for myocardium, ntabwo ikunda gufatwa n'indwara nyinshi uretse ziriya za ischemia, and there are tumors bita rhabdomyoma, which is very rare, niyo bita myxoma, so zikunda kugaragara ku bana, ariko they are rare tumors of the heart. There are not many. Personally, I have not seen any case of with a heart tumor. So then we go to the pericardium. So as you know, our membranes, peritoneum, pericardium, and so on, burigeze ari membrane ebyiri, visceral and parietal. Visceral ifatanye n'iyo organ, niba ari pericardium, visceral ifatanye n'umutima, ibyomatanye, hanyuma parietal ibiri kure, hagati yazo harimo fluid gakeya gatuma umutima igihe utera, ya fluid ni lubricant ituma umutima ugenda unyerera, utera kubusimbuka usa n'usimbuka ku buryo bworoshye. So the diseases which can affect this area is the effusion. Wasanga umuntu afite amazi yuzuyemo hagati y'izo membrane zombi, yita pericardial effusion. Can be hemorrhage, can be inflammation. So all these can happen or you will see these cases. So impamvu zizitera ziratandukanye, as you have read or will read. Icyo ugomba kumenya ni ukumenya ikibazo afite ni ikihe, then what to do. And so effusion, it is usually transudate. I hope you remember the difference between transudate and exudate we saw in and inflammation and edema and so on. So transudate, it is poor in proteins. So when proteins are there, are high, have high concentration in this fluid as compared to the plasma, then it is called exudate. Sorry. So this can be caused by infection, autoimmune disease, the heart problem itself, congestive heart disease, renal failure, cancers, myocardial infarction, drugs, radiation, and so on. So usually there will be a low blood pressure. Kubera iki umutima iyo ujya gutera nabivugaga urabyina urisanzura, umutima urisanzura muri iyo saka yawo. So igihe rero huzuyemo fluid cyangwa ikindi icyo ari cyo cyose, ntabwo umutima uzisanzura, bityo gutera uzaterana imbaraga nkeya. That's why there will be low blood pressure, ahumeke nabi, dizziness, chest pain, and so on. If the heart is very much compressed, then we call it cardiac tamponade. Bibaho, I remember just last year there was a child at Sashika where hari huzuyemo amashira, there's too much pus. So as I said, because I sit in the summer office with the cardiac pediatrician, twagiye so yagiye kumukorera ponction turajyana. So there was too much pus. So when the pus was removed, umwana yatangiye guhumeka neza. Ikibazo nuko kubera impamvu yayiteye yari itaravaho, yakomeje kongera kwiyakimira, bakongera bagakora puncture. But bamushyize ku antibiotic, umwana yarakize arataha. Ariko icyo gihe ni cardiac tamponade, umutima utagishobora gutera kubera ko ukikijwe cyangwa se uri compressed by a fluid. Can be blood, pus, or just any other fluid. So the pericardial hemorrhage, it can be caused by bleeding in the pericardial sac, and the causes are many. Usually it is trauma, ruptured, for example, ruptured aortic dissection, nibindi. So I remember there's a time we just went to the Ministry of Health for a meeting. Then the DG of CHUK and the CHUB were bari kutuganiriza batubwira bari baherutse kubona umurwayi ni umuntu ukunda kugira imbaraga uriye ngo ashobora arwanaga n'imbogo, ntabwo nzi impamvu ajya kurwana nazo. So icyo gihe rero imbogo yari yamubashije, noneho imutera ihembe, mu kurimutera riragenda ryinjira mu gituza, rinyura neza neza hejuru gato ya cross of the aorta. Nuba ko igiye kurishwanya ko riba yari guhita fairumika. Rinyuraho hanyuma rirakomeza, bahita bamuzana kwa muganga. So yari yaviriye muri iyi pericardiossac, harimo amaraso menshi, but fortunately the aorta was intact and so on. Ariko yagize cardiac tamponade itewe na pericardial hemorrhage, just traumatic. So pericarditis, it can be serous, it can be fibrinous. Serous, it means just a fluid abasa n'amazi bisanzwe. Fibrinous abarimo fibrin fibers, akenshi abarimo ibintu bijya gusa na brown. Or serofibrinous if it combines the serous and the fibrinous. Purulent nubu harimo or suppurative, harimo amashyira na wa mwana navugaga. Can be hemorrhagic. Caseous necrosis, we remember, if it is caused by tuberculosis. Another scenario is the adhesive mediastinal pericarditis. Nukuvuga umuntu yagize inflammation igihe kinini hagati muri pericardium, ku buryo byanatumye pericardium y'ubwayo igenda igafatana muri ya healing repair mechanism, igafatana na other mediastinal structures around the pericardium. Birumvikana consequence yayo kimwe niyo hasi, constrictive pericarditis, ibi byombi bizamera nk'afite tamponade. Umutima uzaba ufungiye ahantu utemerewe kuba free to pump free. It will not pump free. So the causes are infections and so on. So there is a long list. So serous pericarditis, impamvu tatugarukaho gutya nukweki, if you do punction, nukora ponction fluid, uzare bukwisa, then you can at least have a smaller list of possible diagnosis. Na uzavuga gusanga afite pericardial effusion cyangwa pericarditis. Aho ubite no ko fluid yagisa, there are possible diagnoses you will make. Nanga uzamenya ko it is non-infectious, or it can be caused by an adjacent infection when riri hafi yaho ariko itaraho ngaho, because n'ibiranga izaba purulent. For example, there is a pruritus. Now, as a reaction, the pericardium also increases its fluid production, but which is not infected. So the slow leakage of the fluid by high specific gravity and the rich protein content in pericardiossac and so on, so around 200. So fibrinous and serofibrinous pericarditis, most frequent these are the most frequent types of pericarditis. So fibrin mixed with serous fluid. So the most common cause is acute myocardial infarction and so on, including systemic lupus erythematosus. So that's uko bizaba bisa kuri if we do surgery or autopsy. So the purulent one will be caused by infective organisms, bacteria, of course, usually. So hemorrhage, there will be blood. Usually there is a cause around there. It's a malignancy, it was traumatic and so on. So it will be easy to diagnose, but the issue will be to treat. So caseous, whenever we say caseous inflammation or necrosis, you understand first tuberculosis. So adhesive mediastinal pericarditis, twavuze ko hariho obliteration of the pericardial sac, kubera hariho adhesion of the mediastinum to the pericardium. We have the consequences. So adhesions ni kuriya muzamubibona muri stage cyangwa mwatinye kuvura. Iyo ubaza umuntu nyuma akazongera akabagwa, usanga organs nyinshi ziba zagize adhesions. Hari membrane zitari natural ziba zaje, ugasanga wenda uterus yarege ifatana n'indi organ bitari bafite aho bihurira, na peritoneum cyangwa na intestine zaje zomatana. So ibyo ni bita adhesions. So constrict pericarditis and so on. So, and I remember my first scientific publication, it was a case umuntu yari yarazengurutse ibitaro byinshi, hanyuma yarabyimbye amaguru, umutima nyine bigaragara ko udakora neza, asa n'afite tamponade. So but when imaging was done, basanga yari afite just a tumor around the heart, not a true tumor, a cyst, ni ukuvuga ni sac yuzemo fluid gusa. So basanze bavuga okay, ikintu biroroshye kuko urumva yibe ikibazo medical cyari bikomeye kumuvura, ariko ibibazo chirurgical, surgical problem and medical problems, they are treated of course differently. So if it is surgical, you do surgery, automatically the patient will be fine. So ni nako byagenze, baramubaze ayikoraho, umuntu yahise aba ibereye. So it is my first case report we published. So yari afite ibimenyetso nk'ibyo ufite cardiac tamponade, ariko wareba mu maraso nta byazamutse cyangwa byamanutse muri factors zindi bya determinant umutima ko wagize ikibazo ubwawo. So usanga ni compression from outside the heart itself. So a good diagnosis then led to have a complete cure of that case. So that's all for this presentation. I rushed because I know you have read, so now we can discuss because you had the time to read this. So this was just a short presentation. If you have questions or inputs, let's take time for that. Otherwise, we'll proceed to the next presentation. Thank you. Questions? Okay, no questions. So 10 minutes break, then we proceed. Okay, but if you have no questions, then I ask you questions. I remember. So, and this most of these questions are from the link I sent you. So this is a 63-year-old woman. She had a sudden onset of knife-like pain in the chest. So you remember I said about the qualities of pains. Are you very constrictive? Are you even like a knife in the image and so on? And it was radiating to the back. She has been previously healthy, except for a history of poorly controlled hypertension. Okay, now things, risk factors of something. She is transported to the hospital, and on arrival, she has a heart rate of 90 per minute. Birumvikana umuntu mukuru normal ni 72 yaruhutse. Respiration 20 per minute, almost normal. Temperature normal, and blood pressure, you see that it is slightly increased. Okay, ni mukuru yego, ariko normal ubundi ni 140 kuri 90. It is the upper limits, ariko uko umuntu akura iyi systolic ishobora kuzamuka. No murmurs, no rubs, no gallops are audible. A chest radiograph reveals a widened mediastinum. So widened mediastinum usually means nuko kuri x-ray icyo ubona ni ibihaha n'ibyo ubona ko ari ibihaha, ibindi biri hagati ubona ko heruruka kubera ko ari solid organ. So ahangaha bishobora kuvuga ko widened mediastinum, it can mean that the heart has increased in its size. Laboratory findings include these: serotonin, creatinine kinase CK, twabibonye kare, creatinine, so hari creatine kinase na creatinine, cyane cyane bireba iby'impyiko, and the glucose, which is normal. Which of the following is the most likely diagnosis? So diabetes ko ntayafite. Ibindi, iki ni ikibazo cy'umutima. So I have not checked if this is above the normal ranges or not. Creatinine bigaragara ko ari nzima. So agaragara ko impyiko ni nzima, diabete ntayo. So what is the diagnosis? So history of non-controlled hypertension, and then having a sudden onset, so acute pain in the chest radiating to the back. So nobody to talk. You can talk. Okay, maybe you have gone through them, you are not interested. So it will be aortic dissection. So what are the indications for this explanation? Cyambere nuko yariwe mu gituza birumvikana, ariko ubu buriwe bukagenda bwiradiatinga mu mugongo. So we know first that yari ikibazo cy'umutima kenshi radiation ijya mu kuboko kw'ibumoso, ariko aorta kubera ko imanuka mu mugongo niyo mpamvu buribwe riho bwaganaga. So that's one. So icyaba kibisobanura kindi ni iki, ukubera ko yari asanga hypertension which is not controlled. Ibyo bishobora gusobanura ko yagize atheroma or atherosclerosis in the aorta, noneho atherosclerosis ahangaha yari ibaye complicated into dissection. So I have more questions. Let's see the. Okay, this we have read. So this is a multiple. This is not MSQ. This is matching. Sorry, I did a mistake here. So a matching question concerning cardiovascular diseases. Of course, there are some questions you can answer after the second presentation. Ariko bireba umutima no twabisubiza. So which among these items on the right side can be matched to this first, the second, the third, and the fifth items on the left? So angina pectoris can be matched to which of the features on the right side?
Stenosis.
Which is stenosis? Because here we have stenosis in B and stenosis in C. Which one?
Coronary stenosis greater than 75% and no plaque disruption.
Yeah, I think so. Because if it is, when it is plaque disruption, it doesn't cause a stable angina, it can cause other things. So, and you want it to match it to unstable angina.
B.
For severe coronary stenosis, frequently plaque disruption.
Okay. Okay, there are things we have not seen here, but have to know also. So if there is a fat in a ventricular wall or in its septum, what will be the consequences, or what things we can connect from this right side? Anybody?
I would say
Victor.
dilated cardiomyopathy.
Dilated cardiomyopathy.
Yes.
I think it's D.
D. Why?
D.
Why D? Arrhythmogenic right ventricular cardiomyopathy. Why? Why do you think so? Okay, so it is when there is a fat in the ventricular wall. Muzi ko muri physiology cyangwa muri anatomy, muri ventricular wall n'ubundi hanyuramo fibers of Purkinje n'ibindi. So iyo zitari continuous bishobora guteza ibibazo muri ritme y'umutima, cyane cyane ugasanga fibers zimwe zirakora contraction ntizikorane n'izindi. Contraction igomba kubera icyarimwe when that electricity goes through adequately. Iyo harimo discontinuity bituma fibers zimwe ziba contracted ukwazo n'izindi zakuba contracted nyuma wenda y'uduce tw'amasegonda. Ibyo rero bitera ikibazo. So nibyo rero biba iyo harimo fat muri septum cyangwa muri wo, bituma zira fibers zikora contraction mu bihe bitandukanye, then it will create this arrhythmogenic right ventricular cardiomyopathy. So then sudden cardiac death.
Variable coronary stenosis and frequent plaque disruption.
So ubwo yaba igiye ahantu habiri rero.
Iya mbere yagiye kuri C.
Iya kabiri?
Iya kabiri yagiye kuri
Okay.
B.
Iyo uvuze ni F. Okay, sorry. Yeah,
Yes,
you are right.
yeah.
Yeah, you're right. It is F. I thought you were referring to C. Okay. So 1 is with C. 2 is with F. Frequent plaque.
Sorry, sir.
Yes.
Unstable angina is with B, severe coronary stenosis.
No. Yeah, yeah, severe coronary stenosis with plaque disruption. Here, this one goes with sudden cardiac death. Urumva byombi bishobora kujyana, hari ahantu bijya guhurira kubera ko unstable angina n'ubundi akenshi ijyana kuri myocardial infarction nayo infection. Ariko difference hari nuko angaha already there was a severe coronary stenosis ku buryo iyo habaye akantu gato cyane, iyo habayeho akantu gato cyane ahita apfa kurusha ko hano afite variable coronary stenosis and frequent plaque disruption. No kuvuga plaque disruption ntabwo izatuma ahita apfa, ariko izatera angina which is unstable. I think it is what we have seen in the presentation. Kubera ko stenosis hano akenshi ntabwo iba ari nini, ku buryo hiyongeyeho thrombus ntabwo ahita apfa, ahubwo ashobora kuhita kugira angina. Ariko ahangaha ko hari hasanzweho severe coronary stenosis, akantu gato cyane kahinduka kuri atheroma kazatuma ahita apfa. So I think the answer here is the most correct. So for the other one, so we shall come back on this for the vascular pathology. So we'll come back on this after. So it was just a sample of questions. So because you didn't have any questions, so we can have a 15 minutes break, then we proceed with the next presentation.
Lecturer, sorry. Sorry, lecturer.
Yes.
Yes. What was an answer of the first clinical question? I didn't see the answer because I have an internet issue.
I showed it.
Yes.
This one. Do you see the screen? The answer was aortic dissection, and I explained the reason. B, aortic dissection. Okay, so we break for 15 minutes, then we resume with vascular diseases.